Welcome to the Sports Docs Podcast. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
And on each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice.
On today's episode, we're focusing on musculoskeletal injuries, or MSKIs, in warrior athletes with Dr. Matt Provencher. We have some really great articles for you that contribute well to our conversation on musculoskeletal injuries in the military population. As always, links to all these papers that we discuss on the show can be found on our podcast website, www.thesportsdocspod.com.
Are you one of the many surgeons who thinks that getting osteochondral allografts is a complex and time-consuming process? Well, you're not alone. But we're excited to tell you that there is a simpler way.
At JRF Ortho, they get it. They've heard your concerns and made it their goal to simplify the process. They're not just any company. They are leaders in fresh osteochondral allografts, holding over 60% of the global market share.
JRF Ortho is committed to accommodating your needs, delivering allografts usually around 30 days, and it's all on your terms. You choose your scheduling option, whether it's specifying a surgical date, providing a date range, or just requesting the earliest available allograft. Your preferences are their top priority.
And there's more. They offer pre-sutured tendons and meniscus, and ordering is as easy as a few clicks on their user-friendly online ordering system.
So why make it complicated when you can make it JRF Ortho easy? Simplify your allograft procurement today. Your journey to seamless osteochondral allografts starts with JRF Ortho. To learn more, visit jrfortho.org. We'll start off our discussion today with an article from the March 2022 issue of Military Medicine that introduces the Military Orthopedics Tracking Injuries and Outcomes Network, or MOTION. MOTION is an internet-based data capture system that aims to collect and analyze short and long-term patient outcomes after surgical treatment of a musculoskeletal injury. The goal of MOTION is threefold. First, to identify factors that predict a favorable outcome. Second, to develop models which inform the surgeon and military commanders of patient progress, if they are ahead of or on schedule for return to duty, marginally behind, or substantially behind. And then third, to develop predictive models to better inform both patients and surgeons of the likelihood of a positive outcome, to enhance both patient counseling as well as expectation management.
Then from the November 2020 issue of Sports Health, we review the publication titled Identification of Risk Factors Prospectively Associated with Musculoskeletal Injury in a Warrior Athlete Population. This Level 2 prospective cohort study identified 11 risk factors for MSKI, including older age, so greater than 26, female sex, prior MSKI, lower perceived recovery from injury, prior work restrictions, asymmetrical ankle dorsiflexion, decreased or asymmetrical performance on the lower and upper quarter Y balance test, pain with movement test, and also a slower 2-mile run time.
We then wrap up part one with a 2022 Yellow Journal article from the 15th Annual Extremity War Injury Symposium in 2022, authored by our guest today, that summarizes the recent research efforts focused on MSKI in warrior athletes. This paper primarily focuses on post-traumatic osteoarthritis and the role of orthobiologics in lessening the prevalence of this condition, as well as accelerating recovery to return tactical athletes to full, unrestricted duties quickly and as safely as possible.
We are joined today by Dr. Matt Provencher, a board-certified orthopedic surgeon at the Stedman Clinic in Vail, Colorado, who specializes in complex shoulder, complex knee, and sports medicine. Ashley and I had the privilege of training with Dr. Provencher during his time at Mass General in Boston, where he was also the head doctor for the New England Patriots. Dr. Provencher has over 20 years of clinical orthopedic experience in surgical care of both civilian patients as well as the United States Navy SEALs.
He was recently named one of the top 28 shoulder surgeons in the U.S. and also one of the top 28 knee surgeons in the U.S. by Orthopedics Today. Dr. Provencher is the assistant editor-in-chief of Arthroscopy, the Journal of Arthroscopy and Related Surgery, and has published over 200 peer-reviewed articles, authored 5 textbooks, and 148 book chapters. We could go on and on about his accomplishments and awards and contributions to the field, but we'd be here all night. So without further ado, welcome to the show, Dr. Provencher. So welcome to the show, Matt. Thank you so much for taking the time out of your very busy schedule to be here and share your expertise with our listeners.
Okay. Ashley, Catherine, great pleasure to be here. Thank you.
Yeah, no, we're so pumped. I'm so, personally pumped to have you as a mentor, both in residency and fellowship. And I know Ashley as well for residency. So thanks. And so today we're going to be chatting about musculoskeletal injuries in warrior athletes. And you've published extensively on this topic, and you've highlighted that these non-battle musculoskeletal injuries, or do you call them MSKIs, or do you have you don't call them like MSKIs, do you?
MSKI. Yeah, that's what we use. And I guess first of all, what I could say is, congratulations to, both of you. You've done a great job. This is an incredible podcast you're doing and really elevating orthopedic care, and incredibly proud to be, just a very small part of your professional career. So you've both have done an incredible job. So keep it up. Very proud of you.
Thank you. All right. So these MSKIs, they've substantially impact the medical readiness of service members and also place significant strain on the U.S. government and the military health system. And just for our listeners, I'm just going to list a couple of facts. So in the U.S. Army, MSKIs accounted for 73% of all disability cases from 1997 to 2002 and have implicated as the single most common reason for discharge. MSKIs affect over 800,000 service members annually, and on an annual basis, there's over 25 million limited duty days secondary to MSKIs, costing the DoD $3.7 billion. So these non-battle MSKIs represent not only a financial burden, but also a threat to the medical readiness for our military. So part of your work is trying to lessen this burden and optimize care and focus on data collection. So can you tell us a little bit about data collection in the military and, where it was, where it is now, and, kind of where you see it moving?
Yeah, Catherine, this is a great question, something I'm passionate about, near and dear to my heart. And having done now, I just retired at 27 years of military service, of which almost 17 were active, and most of the time in San Diego. We did a bunch of deployments, and it was great. I loved every minute of it. I mean, there were tough days, don't get me wrong, and we had a lot of like we all do, there's tough deployments, but what we found in, almost a coalition of the willing was in the early 2000s, late 90s, early 2000s, we said, we've got a great opportunity to help impact service member longevity. And they were always the fleet, as you will in the Navy, or the active duty commands and the pilot commanding officers, the ship commanding officers, the sub commanding officers, the Marine commanding officers, especially in Army, and everyone. Why is this person out? Why is this man or woman out? Why are they down to duty? Why are you giving them a medical chit? And how do we do a better job about getting our members back? How do we dedicate resources in a little bit of a resource constrained environment back to full active duty and back to being a resource to the military, the government, the fleet, and the taxpayer? And so one of the things we did, Catherine, to your question, is we started on paper a coalition of the willing, people like myself, JT Tokish, multiple others, some therapists around San Diego. And this was, 2002-3 timeframe, well over 20 years ago now. But we started collecting very basic outcomes data, of which we had none in the military. We had a little bit. If you did a little study of a pet peeve project or something you want to look at, or certainly shoulder instability in the military, we were doing a lot of work on. So we had a lot of data on that going back to the 1990s. But what we were really trying to do was do a better job collecting data. And just like with anything, we started the project on Excel spreadsheet and came up with probably something way too long, but probably a 6, 8, 9 page shoulder and a knee questionnaire. We added in hip and foot and ankle for our colleagues. And we had a great collaborative approach from therapists, athletic trainers, strength conditioning, and orthopedic surgeons. And so it was not just about the surgical return. I mean, obviously that was the biggest downtime and the most missed time, but we were always looking at what are all the other things that factor into this equation. And so that's really what started the data collection movement. And certainly there were much smarter people around than I was that helped really drive this forward. But it was a collaborative effort to drive and push this forward.
So this is motion that you're talking about, right? That military orthopedics tracking injuries. So that paper that we reviewed at the start of our episode. So it talks about 3 different goals of this, and one of them is trying to create a model to predict progress as the patient is progressing, and then kind of identify factors that can predict a good or a bad outcome. Is it at that stage yet, or is it still in the infancy in the data collection stage? Has it reached that point?
So it's interesting, actually. So motion got born out of, and this is actually a great story. And People like JT, myself, Ted Gerlinger, Danny White, other people, all these other great sports, or even joint surgeons that were doing a lot of young athletes or even joint replacements in the military. We had to do a better job because we knew we couldn't do this on paper. And so we were literally banging our heads up against the wall because we had to deal with the dot mill secure environment. If we were at Rothman, if we were at Rush, if we were in Vail, if we were at Harvard, we would have had that done a long time ago. So it took us years to get through the dot mill secure environment. And we came upon an entity known as the Army Analytics Group, and they were out of Monterey, California, based just outside the Navy Postgraduate School of all places. Obviously, the Navy was taking the lead there, but I'm biased. The ability for us now to implement a computerized dot mill secure environment to collect data was a game changer. And I got to credit John Dickens, who, the great story, was in his fellowship at West Point, came and rotated with me when I was at Mass General, running the sports program there, and spent a good amount of time with me while he was at West Point. And he said, I need a project. And I want to apply for a PRRP grant. I'm like, excellent. I've been wanting to do this. We got great time. It's right out of the active duty military. This is about 2013, 14 timeframe. And this was the first grant we put in to help set up motion, literally sitting in my office one day after, with obviously other collaborators around the military to help put this together. And that's where it really got started. Actually, was motion was certainly a ton of work by John Dickens, many others that were colleagues. And I apologize if I'm forgetting your name, because there were so many that helped put this together, as you can imagine. And we were awarded a $1 million grant right off the bat. And that was great because we saw the utility in it. And so did the grant reviewers, to collect our data, use our resources. Now, just another aside, we were also looking and already doing this with Navy Special Warfare. So we had already built basically a dashboard, a human performance program. And so we were doing this in parallel, but we needed it for fleet wide and we needed it for orthopedics. The SEAL team, Navy Special Warfare dashboard we were building, were basically collecting 50, 100 wearable, other different data points, Y balance, all sorts of other things, nutrition, sleep, everything to put together to try to optimize the Navy Special Warfare athlete, if you will. And so we were doing a bunch of these things in parallel. It was a lot of fun, learned a ton.
And what, just so I totally understand, what was the difference between the modeling for the warfare and motion? Like, what are the different types of goals?
Yeah, motion was really just based on, almost an outcomes database we would use in orthopedics, but it was really tailored to some of the stuff we also did in the military. For us, it was important to know, in certain, as a Marine, how many pull-ups you could do, how many push-ups, and how your 2-mile run time was as a Marine, or mile and a half, your other PRT scores. Those were important because that was a surrogate of being able to return to duty, fitness for duty, and the main Army, Navy, Air Force use that as big data to see how everyone was doing. In the SEAL team, we already knew all that stuff. I wasn't really worried about how many push-ups and how many pull-ups. They've already validated that. What I was looking at really from there was a human performance program, and people like Jason Jagchu and Mark Rogo and many others helped put this together and spearhead this, again, starting on paper, but then working now with some groups, one of which is Spear Titus, to help us put together another secure environment to have this data and dashboards to be able to advance human performance. And so, Catherine, to your world, a ton of physical therapy data. But unless you input that in smartly into the system and use some analytics behind it, it's a N of one type of thing to make a decision. And so what we were trying to do is we did very successfully with Special Warfare, is bring and aggregate all these inputs, wearables, Y balance is a small one, but a gazillion other things to be able to really help us identify where we need to put resources, where there were limitations, where we were seeing injury prevention program. All this was being utilized to help develop that. So it was a very robust system, whereas the motion one was just more of a standard musculoskeletal outcomes database.
Well, and I think that there's so many parallels to sports medicine in the sense that, all these things, all these inputs give us a lot of information of like, who do we need on staff? What kind of qualifications do those types of people need? How much should we budget for X, Y, and Z? What type of equipment do we have for these like team members? So can you share a little bit of insight on how that sort of overlapped with your Patriots time?
Mhm.
So when the Crafts hired me for the Patriots, one of the things Belichick first told me was, Matt, I'm pretty good at picking Super Bowl teams here, but you got to help us and, do a little bit better. And so what I quickly realized is Bill Belichick was never going to learn doctor speak, never going to happen. So I had a way to learn coach speak a little bit better and distill down what was important for the coaches, what was statistically important, everything from snap percentage, even like fantasy points, a surrogate for performance, and all these other things that it's kind of cool to put together and look at a gazillion different variables. And there we had a ton of really good inputs. And now it's just about putting together the dashboard, the database, the integration, putting some analytics behind it. And we use it not only for, the 53 main players plus the 10 practice squad, but you'd see 180 free agents come through every year. And every free agent has unique things going on. And so, we went down and were able to grade and we had data on all this and how combine folks did to free agents did. We had a grade, an ISACOS grading scale of meniscus. If you had a perfect meniscus, you had 9 out of 9 points on the medial side, 9 out of 9, 18 points total for your knee, a medial lateral meniscus. And so we would go through and grade these anterior, middle, posterior horns of meniscus on, I don't even know how many MRIs de-identified, and then follow performance all in a de-identified fashion to be able to know how meniscus, cartilage, other ligament things truly impacted performance. Because I can tell, well, but he's got a bad meniscus, he's got bad cartilage, you got this. We gave him a medical grade, but that necessarily wouldn't translate to performance. And so that's what we did, because that's what we did with the SEAL teams. We took all this stuff and they just want to know, Doc, am I ready? Can I go? Performance, what do we do? That's all they want to know.
So you brought up a really interesting point about looking at injuries, or I guess, pathology, and determining if that impacts performance. And a lot of the screening tools you talked about performance metrics and how they link up. That Y balance, you talked about the motion capture system. Are there any screening tools or aspects you look at in a patient's history, whether it be Patriots, NFL, or SEAL team, that can predict musculoskeletal injury, that can suggest that someone's going to have a future injury and that we need to maybe handle them differently or send them through a program?
Yeah, actually, it's 100% multidisciplinary, and it starts with a basic musculoskeletal evaluation. And honestly, our therapists, our strength conditioning, athletic trainers are number 1, 2, and 3 in this, in order to help us provide data and inputs in terms of Navy Special Warfare, in terms of the Patriots, in terms of NFL, NBA, NHL, etc. And whether it's wearable tracking, indoors, outdoors. Y balance is absolutely amazing, very simple but amazing. From a joint standpoint, and correlating just Y balance plus everything else, trying to distill out the noise using good statistical methods and multiple logistical regression and all these things we do to try to distill out the right variables. You would find out very quickly what this was. Looking at body composition, body comp, resting metabolic rates, other types of things, how you perform in certain stress environments, body fat composition on top of full body comp and muscle comp and other things. So these were the things we were really starting to look at, on top of all the other basic type of data we had. How fast can you run? How fast can you do a 3-cone? How fast can you pull ups? How can you do strength? How can you do this? But it was way more than that. And that's what the military used to see if you were physically ready. Basically 3 tests. Can you do some push-ups? Can you run a little bit? And can you do a couple other things? They change all the time, but they're not that many. They're not very sophisticated.
Yeah, and that level 2 study, you had that perspective where you're looking at the risk factors for MSKIs in the warrior athlete population. Some of the risk factors that you identified, I think, are really easily employable, for a physical therapist. It's not like you were saying, hey, you have to do this like biomotion camera. There's 12 sensors that you have to get put on. And then the data, it's simple stuff. It was like, like you said, Y balance. It's looking at ankle mobility. It's looking at 2-mile run, things like that. So I think there's a lot of utility in that. We obviously, for our YouTube segments, we actually pop up your papers so people can see them and get the links to everything. So we'll have the links for everybody to see the data and what these tests are and what was shown
That's
to be
great.
valid. But it's very, it's simple stuff. It's not saying,
Right.
hey, you need a lab and you have to have this motion capture system. It's all stuff that can be done.
Well, when we were working together, Catherine, this is what I loved about working with you is you knew all this stuff all along, and we did a number of projects and papers on this, and it's all the same type of thing, but you have to leverage. It's just me. I'm not even
Yeah,
close to the smartest person in the room when we put all these things together. It's putting everything together, leading the
yeah,
team, and figuring this out and say, listen, well, that Y balance is pretty impressive. And guess
yeah,
what? It was the same thing in the NFL. It was the same thing with our Navy Special Warfare, and it's the same thing in our patients. And guess what else? There's almost a work comp thing in a way that
yeah.
prior work restrictions, prior injuries,
Totally.
lower perceived functional recovery, mental resiliency, a resiliency score. I mean, these are all the same themes that keep coming together. I think that's why putting this holistic flavor, actually to your question on every patient I see in clinic, it's not just, we just focus on the shoulder, we just focus on the knee, we get it wrong. And
Yeah.
it's these other things we really have to be cognizant of. I'll tell you another part of the program that really was robust was, and even more robust now, is nutrition, as we all know, and sleep. And
Really?
it's huge. And I got my wake up call with this long time ago, about 17, 18 years ago. I did the shoulder surgery on a, very robust, very in shape seal. And, like athletic trainer kept calling me, Jason kept calling me. He's like, why is this guy not getting better? Why is he not getting better? I'm like, I don't know. And fortunately, it was one of my colleagues there. His name was Kirk Parsley, and he was a medical doc and really had an interest in sleep and endocrine disorders and endocrine axis, adrenal axis stuff. And he says, I'm just going to run a battery of tests on him. He came to me. He's just not feeling great. His shoulder's junky. He's 3 months out. He should be back, but his shoulder's feeling jacked up. And so runs a battery of tests on him. Undetectable testosterone, zero,
Mm.
0.0 something. The body in that world, they were under gazillion, like they all are in the SEAL team, many different deployments, sleep wake cycles completely off, the adrenal axis completely altered, completely shut down. And so by altering that, fixing that, and with some really cool methods that he was using to be able to fix that, shoulder was better in 2 months and better than ever. And his body felt better. So we have to think about this from a holistic approach. And I really got my wake up call about 15, 17 years ago. And, we just focus on this one little area and the biceps and the cuff and this and that. A lot of times you'll get it right, but there's times you won't.
Yeah, I think that's a really good point that you made there. And Catherine can also speak about this too. We've actually partnered with a nutrition company that focuses on that kind of talks about pre-op nutrition and post-op, and how even just that 24-hour period of being NPO going into surgery can lead to pretty significant muscle loss. And then we brace people, we put them in a sling for 6 weeks. And that really in and of itself can hold it back. And as orthopedists, we're not really focusing on that. We're not asking them how much protein they're having and if they're staying hydrated and electrolyte repletion or any of that. And I think we're realizing that's increasingly important, that it's not just the rehab, it's how you're treating your body, as you said, the whole body, not just the shoulder. So I think that's really important. It's a great
Totally.
point.
It's great. It's great you're looking at that too. It's
Yeah.
good.
I think the other thing we always talk about is, we're always like, oh, this new anchor has this, or this new, whatever,
Yeah.
fiber, whatever, like, and you can name names here. It doesn't matter, but,
Are you
we're
looking at me?
always sort of tinkering, with
Right.
little nuance. And then you're like, well, what about all these other things, like optimizing someone's nutrition, optimizing their mental health, optimizing their sleep, all that stuff. And, we don't do a great job about that. So I think it's a good call out that we should be better there.
We're getting better. And I think the sports medicine training is getting better. I think patients are more in tune with it. There's a direct to consumer application here that, patients are asking about it. They're dealing it. They're coming in just better mindfulness, better wellness mindset. And I think that's important, but we have to lead the way.
Absolutely. So I think that's a good time to transition to talking about some specific MSKIs. So we want to start with cartilage disease of the knee. So you published an article in the Yellow Journal last year that was actually a summary from the 15th annual Extremity War Injury Symposium, and focusing on post-traumatic osteoarthritis and the role of biologics in the treatment and the prevention of that. So before we dive into the biologics and all those therapies, we wanted to discuss post-traumatic arthritis first. So when we think of arthritis, we're thinking of an elderly population, right? Is this really a concern in the military population? And if so, what is being done to address that?
Yeah, in some, actually, it's a massive concern and one of our biggest issues. And so maybe just to back up, so for those that don't know who EWI is or what it's about, it's known as the Extremity War Injury Symposia meeting, and was started almost 16, 17, well, years ago at least, and in DC, where a military civilian collaboration would come together with congressional as well as other health policy and or grant funding agencies, especially within the DoD, come together to identify where we have the greatest need. And so why is it called Extremity War Injury Symposium? Well, we need a lot of help and a lot of innovations with all of the IEDs, the blast wounds, the trauma, the joint reconstructions, the prosthetics, all the stuff we needed to do to get better and treat our wounded warrior athletes that were getting injured overseas better. And so my hat's off to people like Jim Fickey and a huge trauma team that really did a great job looking at tibia fractures, grade 1, 2, 3 open fracture classifications, grade 1, 2, 3 other fracture, how to handle tibia fractures, how to do this. And, a lot of really great work from Mark Swinkowski and others came out of this project that was DoD funded, but it now helps us and trauma colleagues treat overseas war injuries and helps us get prepared for anything in the future. And so what's evolved out of this is something pretty interesting, is now we're starting to talk more about, well, yeah, we've got a pretty good, we need more work on the war injury stuff, but the DNBI, disease non-battle injury, is actually the number one thing that takes you out of the military. It takes you out of all the training that the government puts you through, all the money that they pay to put you through whatever specialty you are in the military. And when you really start to drill down to it, it's cartilage, back, knee, meniscus, ligaments, and a few other diagnoses. And these are the leading MSK injury is the leading disability medical board, is how you get separated from the military, and it's also the leading VA disability.
Yeah. I mean, it's a big issue, and you discussed many novel therapeutics in that paper. So you talked a little bit about cell-based therapies for the treatment of post-traumatic OA in the military population. We also had Dr. Tokish talk about those things recently. So that was a lot of fun as well.
Did he know what he was talking about?
We had him on with Nick Verma, and I'm not sure Nick.
Okay, good. So fortunately, Nick was there. Okay, good.
So they were a comedy show, but it was really good.
Yeah, we're hoping next year at AOSSM they let us have a bar. So we're
have a cocktail and take a seat.
I think among the three of us, it could be pretty comical.
So as far as cell-based therapies, in your opinion, what's holding promise for this population, this younger OA type population?
Yeah, I think we've made incredible leaps. The military's done a great job. In the military, I had spinners, meaning the centrifuges and all of the Navy Special Warfare and all the other facilities, because we could do it. I didn't have to, it was covered under our insurance, and we could do it and get it done. So we also collected the data with that, but we know we had a lot of gaps as we were starting to do PRP and BMAC and other cell-based therapeutics, Catherine. But I think the reason we're probably not there is we haven't fully characterized who's going to benefit most from the cell-based therapeutics, number one. Number two is, I think we have to do this more at the point of injury and more at the point of initial knee injury, for example, initial knee effusion, before that cascade initially starts, we're arresting that and preventing PTOA, post-traumatic osteoarthritis, number one funding line basically in the DoD, and there's a reason for that. And so if you really just focus on PTOA across many joints, the knee obviously being one of the leading ones, but you could look at the spine as being very close number two or number one, depending on what year it is in the DoD. We need to look at ways to arrest that earlier and stop the cascade. So it's a little bit of a paradigm shift on our end. And why shouldn't a Navy corpsman or a medic in the Army or Air Force have something that they're carrying around with a ability to intervene early? And you've got a knee effusion, you stepped on the rock, overseas wrong and you blew up your knee, you tweaked a meniscus, tweaked cartilage, heaven forbid you got an ACL, and now you can intervene at the point of injury. I think that's where we have to stop PTOA, because that's the number one enemy we're fighting, and we know that because it's the number one funding line. We need to figure it out.
It's like before that cascade.
So Matt, you had just talked about some interventions kind of at that moment. Are you talking about pharmacologic interventions? Because your paper had talked about cells, signals, scaffold. And so we kind of talked a little bit about cells. The signal aspect seems like that has to do with the inflammatory cascade. Are there any things currently being studied or on the market to kind of interfere with that inflammatory cascade?
Yeah, actually, good question. I mean, and there's a lot of early stuff out there. And when we start looking at the anti-TNF, the anti-interleukin, IL-6, IL-8, IL-9, those are targeted molecules, but it may be even simpler than that. And so maybe there's a targeted drug, but then there may be also a patient-derived drug but we may need some more intervention capabilities and the ability for us to manipulate maybe just a little bit more than minimally manipulated our biologic products, so that we can fine tune these after I draw a venipuncture, take it off your blood, spin it down, but then we add some constituents in there to help stop this PTOA cascade that we already know exists. It's been extremely well studied. We just have to find what that point of care intervention is.
And then what about losartan? So obviously you guys have been studying that a lot, and I'll do just a brief side note because Pat Buckley and JP Begley listen to this, and they are always sort of trying to figure out how they can get on just so they can tease me. But, so Ashley, you may or may not know this. So I was worked on the losartan study when I was a fellow in Vail. And I would fly, somewhat regularly to Houston to do these surgeries on rabbits. I still get texts from JP and Pat intermittently about like rabbits and just like trying to make me feel bad for doing an animal study. And so I'm sure I'll get a little bit after that. But so
the bunny study.
Yeah, the bunny study. They would send me these.
Yeah, and envy of your co-fellows is always a challenging thing, because you had an award-winning project at AOSSM and many other places, Catherine. So
just
jealous. I called her envy. I was trying to be nice, but yeah.
So they were. Obviously, it was a great experience. For many reasons, obviously clinically and being in Vail and having awesome mentors, but I was pretty lucky co-fellow wise.
Yeah, no, that was a great project. And that was really early in the, where we go with losartan. So an anti-fibrotic agent, obviously utilized for blood pressure control. And so obviously it's FDA approved in a marketing realm for blood pressure, but it's not FDA approved for anti-fibrosis in joints and around that. So we use it off label in a very low dose. You certainly have to monitor patients' blood pressure, but there's been some pretty compelling evidence. We have some in the knee and post-scarring in the knee, and maybe post-arthroplasty with shoulder. Dr. Philippon with the hip stuff, my partner. It's a ton of great evidence that scar and adhesions after hip injury or hip surgery can be beneficial. And so these are some of it's early. We haven't completely solved it, but it's another adjunct in a challenging patient where you're worried about arthrofibrosis. We'll use losartan. We'll also use doxycycline as well. We'll use some other adjuncts. We'll do intermittent PRP to keep inflammation down, but not put too much cortisone in. So we're really trying to help post-scarring. Scarring's tough in patients. I have a whole practice of scar mitigation, and I'm sure we all do, because it hurts, it aches, it causes a lot of issues. And so to get good healing yet minimize scar is the next evolution in where we go with this.
Now, I know, Catherine, your study was injecting it intra-articularly, but then some other studies talk about taking it orally, and I assume with the hip injury. So are they doing both the doxycycline and the losartan oral and intra-articular, or is it mostly oral and systemic use that you see?
And I wouldn't have the latest update, but I believe Philippon was just doing it oral, wasn't he?
Yeah, oral, 12.5 milligrams, generally twice a day of losartan, Ashley. Very off-label for the injectable. So But we are studying that in animal models now to
Mhm.
look at what's toxicity. And we had some Japanese international scholars here the last couple of years, and they were doing some really good work looking at cartilage um, dose dependent relationship and whether or not we could even use that as a injectable in the perioperative period.
Yeah.
That's
More to
great.
come on that.
Yeah, more to
We look
come.
forward to it.
Yeah, it's cool stuff.
Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the first part of our discussion as much as we did. On the next episode, we'll continue our conversation with Dr. Matt Provencher and shift our focus to management of ACL tears in the military. Please make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and now on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. We love your feedback. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod and Twitter at thesportsdocpod. Stay fit, friends.